Now, the NHS is occupying a prominent place in our national consciousness at the moment as we head to an election and ponder how to keep the ship well stocked and afloat. So how's it doing? Now, we often give you data on this kind of thing, waiting times, etc. But let's have some on-the-ground insight into the NHS in England. Our filmmaker, Stuart Denman, spent some time with the eminent neurosurgeon, Henry Marsh, at St George's Hospital in South London. Mr Marsh retires next month, but before he does, Stuart wanted to see, through his eyes, how national health policy affects everyday life in a good hospital. Well, as you might expect from a piece about a brain surgeon, the film contains images of brain surgery.
But the aim of the op is to remove it completely and hopefully cure her. It's like this every morning. I literally never know when I go to work whether I'm going to get any operating done or not, because there's always a problem of whether we've got beds or not. Any bed? But that's ridiculous. If I'm going to operate on somebody's brain, most of the patients need to spend the next 24 hours with one nurse looking after them, and that means in an intensive care unit. The intensive care unit could be full because there are patients who no longer need to be on the ICU, but we can't transfer them to the ordinary wards because the wards are full, and the wards will often be full because we can't transfer patients either home or back to their local hospital. So we need to clear somebody off the wards, yeah? Right, well let's go to the wards and try to find out. So it's now 9:20. We're supposed to start at 8:30 and nothing is happening. This is every day, it's like this every morning. And essentially it's because we have too many emergencies. We only get paid 30% of the tariff for doing too many emergencies, and we have all these targets for doing routine non-urgent cases, and many of the beds will have relatively non-urgent cases in them because of that. And then of course the other problem, if you cancel a case, a relatively urgent case, it still has to be done. So you then bounced onto a list later in the week, and that means another patient. So it's all like ping pong balls in a tube. Without any surplus capacity, with endless problems like this, because you can't really run a safe emergency service without surplus capacity. Morning, Sue. Morning, Mr Marsh. We need a bed. 20 years ago, as a senior surgeon, if I said do this, it would happen. Now I'm just one of a whole series of competing pyramids of authority. So it's always endless negotiation that has to go on. You end up with the conclusion, yes, we send for the patient, but we spend over an hour just sort of talking about it. So we can start, can't we? The whole system is extremely inflexible. Yeah, okay. And because there's no surplus capacity, it is always just on the edge of chaos. But of course it's patients' lives at stake. Obviously, you can't allow it to become chaotic. Well, of course it is. Of course it's an emergency. She's going to go blind, if she doesn't have surgery. One of the problems I have now that I'm reaching the end of my career is I have to spend more and more time training rather than operating myself. So I have to watch and then take over if need be. But Tim, in fact, is fully trained and would, in fact, be replacing me as a consultant in a few weeks' time. So this calls for great patience on my part. I sort of stand here or sit down somewhere for hours rather than do the operating myself. This shows a very typical tumour, which is almost certainly completely benign, called a meningioma. It's not actually in the brain, but it's pressing on the brain and then indenting the brain. Without treatment, she'll probably go blind within the next few weeks, it might be months, and then she'd die shortly after that. If there are problems with getting patients treated, it's not the lack of enthusiasm by the surgeons. Isn't that true, Tim and Sammy?
Yeah,
yeah,
sure.
We all want to operate. We're happiest if we're operating in the theatre all day.
For sure. Well, it's the travesty that we spend such a little amount of time.
Well, it's bizarre.
Absolutely.
Yeah. There's an increase in the number of doctors, but no increase in the number of beds or operating theatres. And it's a simple thing, but if you have a chain, making one link in the chain stronger does not make the chain stronger. So if you have more surgeons, if they haven't got the facilities to operate, they'll sit around twiddling their thumbs. Well, I will sit down. I do feel very strongly that healthcare is incredibly complicated, it's incredibly difficult, and incredibly expensive. And the quality of discussion at the level of politics, particularly with the general election coming up, is very poor and very low. I'd like to feel one could understand what they were saying, they actually understood the nature of the problem, which is there's basically a lack of money going into healthcare. And whether you therefore accept the need for waiting lists and queues. If you have something which is free, as healthcare is in this country, if it's in short supply, as it is in this country, queues are inevitable, a waiting list is inevitable. And to pretend that with targets and things like that you can get rid of waiting lists is I think it's dishonest, to be honest. It's like floods, you have flood meadows. So when the river is in full spate, you can deflect the water into a flood meadow and then drain it down more slowly. That is the function of a waiting. It's very simple economics. As I said, if something is free and in short supply, you have to have queues. Otherwise, it becomes shambles, a free-for-all. And if the routine cases are all competing with emergencies, that's clearly wrong ethically.
So longer waiting lists, fewer cancellations?
Yes, there would be. I'm not saying it's all disastrous. As you can see today, we're getting the work done, but in an atmosphere of constant, to me it seems, constant shambles and chaos. So Marius, what's happening bed-wise with your chordoma?
So there's no ITU bed, so it will have to cancel it and see whether we can do it later on in the week on Thursday. They might be able to clear up a bit later, but if they do clear up a bit like 4 or 5 o'clock, it's too late. It's too late. It's of no use to me.
See, that's another frequent problem. It takes, even if you can clear the bed often won't be available until late in the day, and then we're reluctant to start very difficult major surgery in the evening. And I was saying to Stuart that my impression is like this every day now. 5 years ago it was like this from time to time, but now every day we have this problem of not...
It would make more sense that if it's likely that we have a bed later on to start the case and worry about it later, especially a case that would last 4 or 5 hours, but we can't.
But we can't, so that's because I suppose there's some managerial protocol saying we mustn't start the case unless there's definitely a bed. So it's deeply inefficient. That's burnt tumour, but because she's young, I want to try to get all the tumour out, or it's very likely to grow back. If she was older, I'd say, oh well, with a bit of luck she'll die from old age. But it's all about decision making, how much of a tumour to remove. I think we can call that complete removal. Well, I think she'll do well. So, though the wellness is also that in 10 years' time there's no recurrence of a tumour, you know. So, to be honest, I think quite no, but I think it's unlikely that will grow back. So the situation now is there should be an ICU bed, but it might not be ready yet because they can't move the patient yet.
This operation will finish when?
Well, this will be finished in half an hour.
So you have half an hour to find a bed?
Well, yeah, but if not, the patient just stays here. We wake it up, but Dr. Dinsmore has to act as an intensive care unit nurse because they won't look after extra patients, you see. We now have a bed, but not a bed space. So that's a step in the right direction. They're hoping there'll be a bed space in half an hour.
Do you normally have to go and fetch your own bed?
No, but it saves time if I do. If I didn't bring the bed, they'd have to get somebody else to do it. They'd have to be telephoned and they might be doing something else.
Do you think you actually have an unusual amount of clout in this hospital?
I probably do because I'm the senior surgeon. I've been here a long time.
So what will happen when you go?
I think things will slow down, I suspect. But I may be wrong. I hope I'm wrong. Well, the problem is, and this is why it's difficult for the government, you know, healthcare is a bottomless pit. If you created lots more ICU beds, the doctors will fill them up. So it is very difficult. If you could spend the entire national income on healthcare, the whole population still dies The problem is, where do you set the limit? Over-treatment is a huge problem now in the Western world. We treat people in very poor health, who are very old, who've got really very little realistic chance of useful survival. The hope to solve this problem is a better educated public, when patients become more like doctors, in the sense they're informed consumers and can make sensible choices about what sort of treatment they should have in the latter years of their life.
Florica, hello, it's all finished.
I'm sure on the whole most doctors as they get older get more sympathetic, because you start to identify more with patients. And I see my poor old patients stuck in some cramped standard issue NHS bay, unable to sleep at night, worried they're going to die, frightened in pain. I think sooner or later that will be me in that bed.